When we talk about food-related diseases, obesity, type 2 diabetes, cardiovascular disease, even certain cancers, the focus almost always centers on diet, what we eat, how much sugar we consume, the dangers of processed meat, the benefits of fiber. But this tight framing may obscure a deeper truth. Food doesn't operate in a vacuum. In reality, lifestyle factors like stress, sleep quality, exercise habits, and socioeconomic status often shape our dietary choices, influence how our bodies respond to food, and even determine who gets sick and who doesn't. If we ignore these variables, we risk oversimplifying the science and underestimating the true drivers of chronic illness. Consider this. Two people may eat similar diets in terms of nutrients, calories, and food categories. One lives in a low-income neighborhood with limited access to fresh produce, high levels of environmental stress, and little time or energy for exercise. The other lives in a resource-rich area, has control over work-life balance, access to healthcare, and a supportive social environment. Even with similar diets, their risk profiles are dramatically different. That's because the body doesn't process food in isolation. It processes it through a lens of chronic stress, hormonal disruption, physical activity levels, and sleep rhythms. Chronic stress, for example, raises cortisol levels, which directly promotes fat storage, particularly around the abdomen, while simultaneously increasing cravings for calorie-dense, high-sugar foods. This creates a feedback loop where stress fuels poor eating, and poor eating further disrupts hormonal balance and metabolic health. Stress also alters gut function and microbiota composition, which can affect nutrient absorption and immune responses. These aren't fringe effects. They're central to how diet interacts with the body. Sleep deprivation is another underappreciated factor. Studies consistently show that even one night of poor sleep reduces insulin sensitivity, impairs appetite regulation via hormones like leptin and ghrelin, and increases the appeal of high-sugar, high-fat foods. Chronic sleep loss doesn't just make us tired, it makes us metabolically vulnerable. A diet that might be manageable for a well-rested person could push a sleep-deprived one into pre-diabetic territory. Then there's physical activity, which not only burns calories but also improves insulin sensitivity, reduces inflammation, and promotes better appetite control. Two individuals eating the same number of calories from the same foods may experience wildly different health outcomes, depending on how active they are. Yet food is often blamed in isolation, while movement is treated as a separate or secondary consideration. But perhaps the most powerful, yet consistently overlooked, influence is socioeconomic status, SES. Low-income individuals face a host of structural barriers that distort food choice and health outcomes: limited access to healthy foods, marketing of ultra-processed products to vulnerable communities, unsafe environments that limit physical activity, and high levels of chronic stress. Add to that inconsistent access to healthcare, educational gaps, and occupational pressures, and it's clear that diet alone cannot explain disease risk. In fact, socioeconomic disparities may explain much of the difference in outcomes seen in nutrition studies. This complexity doesn't mean diet isn't important, it's crucial. But the tendency to frame poor health as the result of poor personal choices, especially around food, can lead to victim blaming and ineffective interventions. Telling someone to eat better without addressing the stress, poverty, or environmental toxins shaping their choices is like prescribing medication without treating the infection. It also means that many dietary studies, especially observational ones, can mislead. When food intake is associated with disease risk, but SES, stress, and activity level aren't adequately controlled for, the diet may be the most visible variable, but not the most powerful one. This helps explain why some nutrition studies show inconsistent or conflicting results. If we don't measure or adjust for lifestyle context, the conclusions may be incomplete or even wrong. The solution isn't to abandon nutrition science, it's to broaden it. To understand chronic disease, we must treat food as part of a larger ecosystem of human behavior, biology, and environment. Future studies need better tools to measure and control for these lifestyle variables, and public health policy must stop treating diet as an isolated behavior. Instead, interventions should address the why behind poor eating: stress, time poverty, income inequality, neighborhood environments, and cultural norms. In the end, food is only part of the story, and perhaps not always the most important part. If we want real progress in preventing and treating chronic disease, we need to stop asking what people eat in isolation and start asking why they eat it, how they live around it, and what systems shape those patterns. Until then, we may be focusing on symptoms and missing the root cause.